In emergency resuscitation, the absolute first priority is stabilizing the airway, breathing, and circulation protocols before making any definitive diagnosis. When you're faced with an undifferentiated shock scenario, the strict next best step logic requires you to stabilize the patient before moving to any diagnostics. You've got to attach the monitor and defibrillator, get oxygen flowing, and immediately obtain 2 large-bore IVs. And remember, if peripheral IV access fails during an emergency resuscitation, immediately establish intraosseous or IO access. Don't wait. Okay, let's dive into this. For a pulseless patient, you start CPR immediately and classify the rhythm into 2 distinct immediate intervention branches. On one side, shockable rhythms like ventricular fibrillation or pulseless VTAC require immediate defibrillation. On the other side, unshockable rhythms, specifically pulseless electrical activity and asystole, mean you keep going with continuous, high-quality CPR, no shock. Now, for PEA, that's organized electrical activity without a pulse, the management pathway is relentless. You're pushing high-quality CPR, securing the airway, establishing IV or IO access, administering epinephrine every 3 to 5 minutes, and doing rhythm and pulse checks every 2 minutes. Concurrently, you must aggressively search for reversible causes. Let's drill the 5 H's: hypovolemia, hypoxia, hydrogen ions or acidosis, hypo or hyperkalemia, and hypothermia. And the 5 T's: tension pneumothorax, tamponade, toxins, thrombosis, either pulmonary or coronary, and trauma. When sorting shock clinically, always look at extremity temperature and pulse pressure. Hypovolemic shock presents with low preload, cool, clammy extremities, and often a bleeding source. Trauma requires finding external bleeding or internal blood loss in the chest, abdomen, pelvis, or thigh. Hemorrhagic shock demands compressible bleeding control and early blood products, limiting massive crystalloids while definitive hemorrhage control is arranged. Distributive and septic shock, however, present with vasodilation and low systemic vascular resistance. But be careful here. Early septic shock can be really deceptive, presenting with warm extremities, bounding pulses, and a wide pulse pressure before progressing to later cold shock. The specific sequence for treating suspected sepsis is absolutely crucial. Give prompt, broad-spectrum antibiotics, obtain blood cultures only if they don't delay therapy, start crystalloid resuscitation for hypotension or impaired perfusion, measure and trend the lactate, achieve source control, and add norepinephrine if the hypotension persists after fluids. Watch out for this major exam trap. You must stop diuretics in septic shock unless a specific, overriding competing indication exists. Section 2. Obstructive shock pathologies. We are now shifting our focus to identifying mechanical barriers to cardiac output. Remember, obstructive shock means low cardiac output with elevated venous pressure. Tension pneumothorax is clinically anchored by 3 things: hypotension, hypoxia, and unilateral absent breath sounds. If you see this, the immediate, non-negotiable next best step is needle decompression, followed right up with a chest tube. And this brilliantly illustrates the pathognomonic radiological signs of a pulmonary embolism. On the left, we're looking at the Hampton hump, a wedge-shaped peripheral opacity indicating a pulmonary infarct. And on the right is the Fleischner sign, showing proximal enlargement of the pulmonary artery. When a massive PE causes actual hemodynamic instability, evident through hypotension, hypoxemia, acute dyspnea, syncope, elevated JVP, and right ventricular strain, the algorithm branches directly to systemic thrombolysis, or embolectomy when appropriate. Direct your focus here. Compared to a normal chest X-ray on the left with clear costophrenic angles, the right image shows a dramatically enlarged water bottle-shaped cardiac silhouette. This classic appearance indicates a massive pericardial effusion, leading to tamponade. Now, what's really interesting about this slide is the electrical alternance. Notice the alternating amplitude of those QRS complexes. When combined with sinus tachycardia, this finding is highly specific for a large pericardial effusion. Let's talk triggers. The definitive triggers for immediate pericardiocentesis in an unstable patient are hypotension, jugular venous distension, muffled heart sounds, and pulsus paradoxus. Furthermore, a bedside ultrasound will show diastolic chamber collapse. Section 3. Cardiogenic shock and ischemia. We're keeping the clinical momentum going and shifting our focus to acute coronary syndromes and left ventricular failure. Here is the critical pharmacological management for acute coronary syndrome. Pay strict attention to the contraindications highlighted in red. It is absolutely vital that you avoid beta blockers in patients presenting with cardiogenic shock, acute decompensated heart failure, or severe bradycardia. For cardiogenic shock treatment, you're dealing with low cardiac output, pulmonary edema, elevated JVP, and high filling pressures. Do not reflexively give large fluid boluses. It's a trap that will just worsen the pulmonary edema. Instead, you must provide inotropic support using drugs like dubunamine or milrinone to treat the end organ hypoperfusion. Take a look at the bottom row of this table mapping MI location to coronary vessels. Right ventricular myocardial infarctions occur in up to half of all inferior MIs due to right coronary artery occlusion, which you'll see indicated by SD elevation in leads V4R to V6R. So the crucial point is this major exam trap. A patient with a right ventricular MI presents with marked hypotension and low normal JVP. Why? Because they have an incredibly high sensitivity to intravascular volume depletion. The next best step here is to give an IV saline bolus. You absolutely must avoid nitrates and preload reducers. This ECG strip shows monomorphic ventricular tachycardia, characterized by regular RR intervals, wide QRS complexes, and occasional fusion beats. Recognizing this is critical because this reentrant ventricular arrhythmia is the most common cause of sudden cardiac arrest in the immediate post-infarction period. Moving on, long-term optimal medical management is completely indispensable for all post-MI patients. The core protocol strictly includes dual antiplatelet therapy, beta blockers to reduce oxygen demand and lower arrhythmia risk, ACE inhibitors to inhibit remodeling, and high-intensity statins. Section 4. Toxidromes and reversible causes. We are transitioning to our final segment covering specific toxicological causes of cardiovascular collapse. When it comes to digoxin toxicity, recognition is anchored by life-threatening arrhythmias, severe gastrointestinal symptoms, and distinct neurologic features, most notably color vision alterations. Let's move to and see how this builds. For beta blocker toxicity, map this stepwise reversal pathway strictly. First, secure the airway. Next, administer IV isotonic fluid boluses and IV atropine to manage initial hypotension and bradycardia. If they have profound hypotension that's refractory to those steps, the specific next step is IV glucagon, which directly counteracts the toxicity by increasing intracellular CAMP. Following the return of spontaneous circulation, or ROSC, stabilization must be immediate and systematic. Support oxygenation and ventilation, strictly avoid hypotension, obtain an ECG to check for coronary occlusion, treat the precipitating cause, monitor the patient's temperature and neurologic status, and promptly transfer the patient to critical care.